So you think of a conflict with, two sides of it. The person is emotionally between a rock and the hard place. On the one hand is submission to rules and authority, which leads to shame and humiliation and rage. On the other side is defiance, which leads to terrifying fears of punishment and retribution. Both of those options are equally frightening and unacceptable. And then the entire personality gets constructed around, how do I squelch all of the emotions on both sides of the conflict? And then that's where the more observable, features of obsessive compulsive personality come into play. Well, one way you do that is you live in the realm of thoughts and ideas and reason, and not in the realm of feeling.
All right, welcome back to the podcast. I am joined once again with Jonathan Shedler. He was on a previous podcast, and it is a joy to have him back. And I was reading one of his book chapters, and called The Personality Syndromes. It is in a primer on personality disorders. Feinstein, who has been on previous podcasts, organized it and wrote some chapters as well. And in this chapter, he talks about different personality types and bases it off of his own research and his clinical practice and years of reading and supervision and probably individual therapy. So
all of the above.
You get true expertise when you combine all of those things together. So I want to jump right in and talk about obsessive compulsive personality disorder, OCPD, but in this case you're just calling it obsessive compulsive personality, which is,
well, and there's a reason for that.
Okay.
If you want to start there.
Yeah, let's go.
So there's a whole tradition that originates in psychoanalytic psychology, and really goes back more than a century. And the tradition is recognizing that there are certain kinds of personality patterns or configurations that we see over and over again. And a clinician, a psychotherapist who understands these sort of familiar, recognizable patterns, really has a kind of a map of the patient's interior terrain and the terrain that they're going to navigate in treatment. And the reason my chapter says, for example, obsessive compulsive personality or narcissistic personality and not personality disorder is because in the clinical tradition from which these understanding of these personality patterns arose, these were not inherently pathological.
Mm-hmm.
They're not disorders, right? We're talking about people's personality, meaning, not what disorder do you have, but rather who are you as a person, right? So really the starting point for a discussion is recognizing every human being in the world has a personality and a personality style. Mm-hmm. And, how can a personality be a disorder?
Yeah.
So the idea is, well, there's no clear dividing line between what we call a personality style and what somebody looking at it through a clinical lens would call a disorder, right? The word disorder is really just a kind of a linguistic convenience, a shorthand for clinicians. And when they say personality disorder, what it really means is there's something about this personality, a person's personality style, that's so rigid, so extreme, so limiting, causes dysfunction or suffering, that is a kind of a convenience. We use the term disorder, but we're really superimposing, a medical term disorder on something, that every human has, and that really falls along a continuum or a spectrum. So people have narcissistic personality styles or obsessive compulsive personality styles that are not disorders. And I'm talking a lot, but this helpful. Is a really important point to make. DSM kind of fucked things up. in terms of the clinician's understanding and the public's understanding of personality. Because what they did is they took, in order to shoehorn these personality styles into a manual of quote unquote disorders, what they did is take for personality styles that were familiar in the clinical literature, described them in their most extreme and pathological form, in some cases to the point of caricature, and appended the word disorder to them. And the reason I say it fucked things up is, as a result of DSM, they've completely disconnected the concept of personality from the clinical understanding that it originated in. It artificially turned everything into a disorder. And now what has happened as a result is we have clinicians, psychiatrists, psychologists, other kinds of mental health professionals who think that personality can just be ignored entirely unless the person has a diagnosable DSM personality disorder, right? So the effect of sort of ratcheting up the severity of all of the personality styles and labeling the disorders, I mean, the effect is they've just dropped off of their personality itself has dropped off of the radar screen for a lot of clinicians. And also any mention of personality at all is automatically assumed to be something pathological, and that's really being a devolution rather than an evolution of understanding of personality in the field. So that's kind of my preamble.
Yeah, it kind of creates some rigidity around the and rather than seeing the spectrum, and you have to, you could have someone with different defenses that maybe it's not hurting their life.
Well, but see, everybody has defenses. There's no such thing as
yeah,
a human functioning in the world without defenses. It's not a question of do you have defenses. It's a question of, which defenses and how flexible and adaptable they can be, versus how extreme and how rigid they can be. So we're always talking about matters of degree, and we're talking about continua, not categories. So it's very different for, especially for people, listeners who might have been, trained on the DSM. It's really a very different way of thinking about people. We're talking about, types of people, not categories of disorders.
Yeah, that's helpful. And I think the other thing that the DSM that you noted was it took away the underlying causes and the treatments, really, and just kind of gave like, here's some symptoms that
well, it turned it into something that's clinically useless. If somebody nowadays, if somebody diagnoses a personality disorder, all it really means is this person has significant limitations and they probably pissed off the clinician. Otherwise the clinician doesn't diagnose a personality disorder. It tells you nothing relevant to treatment. And one of the reasons for that is what you said. So personality is not about just signs and symptoms and external behavior. Personality is about underlying psychological themes. It's about how we look at the world, ourselves, how we attach to other people or fail to attach to other people, our habitual and characteristic ways of coping, our motivation, our unconscious themes and preoccupations, right? All of this is about internal experience, not just observable behavior. And what DSM did is, they tried to focus exclusively on observable behavior and signs and symptoms, and left out all of the things that have to do with internal experience and internal psychological processes that actually are at the core of the personality styles. They basically hollowed them out. And then of course, if you take that out, there's no information that's left that's relevant to treatment. There's so knowing somebody has, say, I don't know, a DSM diagnosis of a dependent personality disorder, say, or avoidant personality disorder, what does that mean for how you're going to treat the person differently? What does it mean for what you might do in psychotherapy? And you're shaking your head
Yeah.
correctly, because it doesn't mean anything at all,
Yep.
right? So we've just got these labels that we attach to people, but the labels don't give the clinician any guidance about how to work with the person in a way that can help them, which is ultimately the function of
Mhm.
diagnosis. If the diagnosis doesn't help, then it's useless.
Yeah. I think then it becomes like, well, okay, so how do we come back to what is important with making a clear kind of diagnosis, and then maybe giving some examples of how as a clinician you might use
Sure.
that constructively. So let's jump into obsessive compulsive personality, because I'm like really interested in this. So you talk about how it's conscientious, meticulous, regimented, cerebral individuals.
Those are the outward signs, those are the externals.
Those are the
Yes.
externals. Not in touch with their feelings, only thinking. Living machines.
Yeah, the real tell is, if you ask a person with an obsessive compulsive personality style, whether it's dysfunctional and in the range that somebody might call a disorder, or whether it's, the functional and healthy version of it, if you ask somebody with this personality style, what do they feel? They'll tell you what they think. Right? So it's the use of thinking and reason and logic as as a defense against emotional life.
But isn't reason like the thing that should be in control of the other things, according to Plato,
No,
right? In
hell
control of
no,
the
no, hell
control
no.
of the
Because absolutely not. Because a person with all all reason, all head and no heart, is a very incomplete, limited human being. We, the goal of mature functioning and the goal of meaningful psychotherapy is kind of an integration of head and heart, of mind, mind, emotion,
right.
body. It's
Yep.
about sort of finding harmony and becoming more whole. And you know, the thing is, you can't selectively put the lid on certain emotions and not others. So for example, I've been treating a patient for a while who is very, very successful,
Mhm.
extraordinarily successful, and he's he's one of his central organizing principles is he's really very defended against and afraid of his own anger, you know,
Mm.
and so he's tried to construct his life in a way where you know where he can kind of squelch
Mhm.
not only expression of anger, but awareness of anger. The problem is you can't selectively squelch one thing. What happens is
Mm.
all feeling gets squelched. So along with, the unwanted and frightening, his capacity for anger and rage and aggression, along with that, squelching that is his capacity for joy and
Mm.
spontaneity and exuberance and excitement and desire, emotional connection to other people. It all gets squelched. So no, this Platonic ideal of reason, reason is the master, reason is control of everything. That is not written for humans. That's written for some other species.
Okay, so here's a quote. Under the conscious surface, the person with obsessive compulsive personality is waging epic emotional battles. So are you talking about like how, like, there's a lot of defenses that keep these emotions underneath the surface, right? And it's like but underneath the surface there's a lot going on.
Yeah. So So every one of the personality styles, despite what it says in DSM, every one of the personality styles is really defined by certain predominant unconscious themes and preoccupations. And this is true for every human being. It's not a matter of, healthy versus pathological, or, or this only applies to patients. This applies to everyone. So when we
Mm-hmm.
talk about an obsessive compulsive style, the preoccupation, the unconscious preoccupation is around control, is around controlling or being controlled. And the person is caught in a dilemma. There's an internal
Mm.
conflict. And the conflict is that, that acceding to somebody else's control, to following the rules, you know,
Obedience, obeying,
obedience to, thank you,
deference
obedience
for
to
authority.
authority. Yeah. All of those things feel like shameful, humiliating submissions that leave the person ashamed unconsciously,
Unconsciously.
ashamed, enraged, right, humiliated. It's intolerable. Those feelings are intolerable. The other side of the conflict, right? So one side of the conflict is about submission and how that's intolerable. The other side of the conflict is about taking control and being defiant. And that's experienced unconsciously as, an act of destructive aggression that's going to
Mm.
be met with punishment or retaliation. So you think of a conflict with, two sides of it. The person is emotionally between a rock and the hard place. On the one hand is submission to rules and authority, which leads to shame and humiliation and rage. On the other side is defiance, which leads to terrifying fears of, punishment and retribution. Both of those options are, equally frightening and unacceptable. And then the entire personality gets constructed around, um, how do I, how do I squelch all of the
Mm.
emotions on both sides of the conflict? And then that's where the more observable, features of obsessive compulsive personality come into play. Well, one way you do that is you live in the realm of thoughts and ideas and reason, and not in the realm of feeling, right? So that's why when you ask someone with obsessive compulsive personality, what do you feel about something, and they tell you what they think, right? That's a defense operating, right?
Mm.
It's a moving away from emotional life.
Yeah. And I think it like there's a lack of playfulness that ensues because it's hard to be not in touch with your emotional world and playful at the same time. It's like, can you be purely intellectual and playful?
You can't be, right, because playful is drawing on other parts of the personality, and those other parts of the personality are being squelched. Now let me say, this way of adapting and defending, this way of being in the world, you know, also, you know, it also has some benefits. Every one of these personality styles, you can think of, um, you know, is every one of these personality styles is really like two sides of a coin, right? Where there's some significant cost and some significant benefits. Somebody with an
Mm.
obsessive, higher functioning version of an obsessive compulsive personality is going to excel in fields and areas of life, where reasoning and careful thought and
Mm.
precision is prized. Well, they might be a medical researcher, they might be an engineer, right? Um, they might be
An,
somebody who can, right?
an,
They
an
right, they're,
accountant, a medical biller, a
well, all of, all of the above.
philosopher.
A philosopher, the kind of philosopher who would subordinate emotional life to logic and reason. They might even become a therapist, the kind of therapist who would subordinate emotional life to logic and reason, and builds an
Mm-hmm.
entire theory of psychotherapy purely around, purely around cognitions, which is
Mm.
basically to say conscious thoughts. And so
Mm.
there's a denial.
Yeah.
of, the sort of richness and complexity and layers of emotional life. We can
Yeah.
deal only in the realm of consciousness.
Yeah.
But, somebody who's building a bridge or coding software,
Coding. Yeah.
is maybe very much in their element. It has costs in other areas of their life.
Yeah.
So it's not that this is one more reason why I really want to strip the word disorder from all of these personality styles, because every one of these, has costs and benefits, a bright side and a dark side.
Yeah. Yeah. I appreciate that. So, like, and I think it is a superpower to a lot of people to have that meticulousness and the intellectualization and the rationalization, like in many domains of their life, but often in their personal life with their
A
wife,
lot of
with their kids.
academics have obsessive compulsive personality styles. Hopefully, the higher functioning versions of obsessive compulsive personality styles, and they excel in certain areas. But what's
Mhm.
lost is, as you said, joy, spontaneity, creativity, play, emotional intimacy. Right?
Yep.
Those are the costs.
What I found from working with a couple people over time is they say they can feel the yearning to intellectualize and rationalize, but they can start to notice the emotion underneath and they can choose not to.
Yeah.
And so it's like they have some flexibility there. I don't
and
know.
and that's really the goal of treatment. We don't, and even in the best psychotherapy, we don't turn people into somebody else other than who they are. What we do is try to help them become try to help them become a better version of themselves, a more mature, flexible version of themselves. So it's really nice to have the capacity. I mean, if I were, a patient on a surgery table, I don't want my surgeon acting out of, out of emotions in the
Mhm.
heat of the moment. I want him to be
Right.
thinking, clearly, rationally, logically,
Hmm.
systematically. Right. So, but the flexible version of that is that may be your kind of, that may be where you default to. It's nice to have that as a capacity, something
Mm.
within your repertoire of what you can do. It's not nice for the person to not have a choice about it, where that way of being is obligatory, right,
Mm.
and driven, and
Yeah.
there's no options. So the goal at work in therapy is, to kind of loosen up defenses and create more freedom for the
Hmm.
person.
Okay. So like, let's say you're someone who's a professional and you're like, oh my gosh, you're speaking exactly to me. What I need to do is I need to read more about this so that I can master it and I can totally understand the ideas around it. And that will be my cure.
Well, that would that would be very appealing to somebody with an obsessive compulsive personality, and it would absolutely miss the point, right? And when
Yeah.
you think about it, I said the core conflict or the core preoccupation underlying this is about control. Well, if you're reading it, you're processing it on your own terms, you're in control. You're taking it out of a relational context. It's not in therapy anymore. Now it's between you and yourself. There's
Hmm.
really not much role for another person, certainly a psychotherapist. It's basically saying, I've got this. I'm going to do it in a way that doesn't allow for anything to emerge that might be spontaneous and unplanned. So we go about it in this very, planful, systematic way that, coincidentally eliminates the possibility for something unknown, unforeseen, which is
Mm.
what play is about, right?
Mm.
Emerging
Yeah.
in a freer and more creative way. The other thing that happens in therapy with people with obsessive compulsive personality disorder, you'll make an observation or point something out as the therapist. Perhaps perhaps you respond this way or feel this way because, right? That's the kind of observation I'm talking about, right? With the intent of illuminating something, or
Okay.
or bringing about some insight about something. And a person with an obsessive compulsive personality style will very commonly say, oh, that makes sense. and the clinician thinks they're on the same page. Oh, makes
Mm.
sense. They took it in. No, they're not on the same page at all. And so one way I respond to the patient who says, that makes sense. Is like, are you saying that it just makes sense intellectually? Like, you get it, you understand how that would work, versus is that something you feel and recognize in yourself that you feel to be true?
Right.
Because those are different things. It makes sense versus I see and feel this in myself, and in a way that's real, are really
Right.
quite two different things. And the it makes sense is really a defense against engaging with it. So, and the person, somebody with, a real obsessive compulsive personality, it's not that they're dismissing and saying, no, this doesn't apply to me, nor are they saying it does apply to me. They're sort of operating, intellectually in the clouds. It's like it's not even a question. It's not even an issue for them. Does it or does not? Does it or does it not fit how they
Mm-hmm.
experience things? Right. So when we say, that makes sense, when we say it makes sense intellectually, or you feel it in yourself, what we're actually doing is calling attention to the discrepancy between thinking about something in a sort of abstractly intellectual way
Right.
versus thinking about something in a more intimately personal way.
Yeah. It's like moving back into the body. I think this is where, like, some of the somatic schools of psychotherapy, what they taught me is to sort of retune to like bodily sensations, which is actually really
But yeah,
helpful.
I'm actually not. I agree, but I'm not going there yet. Right.
Okay.
But there's the
Where are we
question of
going?
why do we need to tune to bodily sensations? Right. If we did that with somebody with this personality style, we're skipping over something, and the something we'd be skipping over is the recognition that
Mm,
something is disconnected there, that something is missing. Right?
mm,
So the person says, well, I don't know if it applies to me or not. Right. That's the first important, insight. So you're accustomed to thinking about things, in a way where you're missing the internal cues
okay.
that tell you whether something is right or wrong for you. It tell you how it feels for you. It tells you whether it's what you want or don't want. Right. First comes the recognition the person is missing internal cues. Then maybe they get curious about, well, what do you mean? What kind of internal cues?
Hmm.
Then it makes sense to say,
Okay.
well, let's notice what's going on. Let's notice what's going on physically. Let's notice. Let's start with noticing what's going on in your body, because typically that gets shut out along with emotional life.
Yeah.
But we don't want to. The goal isn't to try to if the patient is building a wall, in this case a wall between them and emotional life, the goal isn't to get around the wall or over the wall or through the wall. The goal is to call attention to the fact that there's a wall being built in the first place, and to
Mm,
get very curious about why this particular wall, why in this particular spot, not somewhere else. How is it being constructed? Why is it being constructed? What purpose does it serve? Right. So before we get in the business of what's behind the wall,
yeah.
let's really understand and feel the presence of the wall.
Okay. So one thing that I often will say, and I'm gonna. It's always helpful to kind of start off with what I imagine might be the most helpful thing, and then to get a different opinion. Is I'll say something like, it makes sense that it's adaptive. It's been adaptive throughout your life to intellectualize or put this more into thoughts than feelings. It may, from what you've told me, feelings have been not allowed. You weren't allowed to be angry when you were young, and so you had to survive, put this into more of to thoughts and push your feelings away. So I may say something like that, and it's like maybe kind of empathizing with the defense and show the adaptive nature of the defense.
I would say that's not exactly empathizing with the defense, because you're describing the defense in a very abstract form. Whereas,
Okay.
in fact, what's going on in the session is something very immediate and personal in the here and now between you. So, you know, emotions have been difficult, and this is, and, pushing them aside and working in the realm of thought, is how you adapted. That may be true. I mean, it is true, but it's also a bit experience distant, right? So, let's make it concrete. You, for whatever reason, you're a few minutes late for your session. The patient's waiting for you, and you come in and say, perhaps you had some feelings about being
Mhm.
left waiting. And the patient might say, no, I understand. You might, you have a life, and perhaps your other session ran late or something came up. Right? The patient is very logically understanding about it. And, um, making it more immediate would be saying something like, all of that is true. You know, those are one set of thoughts that you have about it, but I notice that it doesn't really leave room for any other thoughts and feelings that came
Mhm.
up. Well, there were no other thoughts and feelings.
Right, right, right.
Like it makes
Yeah.
perfect sense. You know, you would start working with that rather than looking for more sort of abstract explanations.
Okay.
Maybe you get to say at some point, it must not have felt very good.
Yeah.
They were waiting for me, not knowing where I was. And the patient says, well, yes, but, I
But you're
understand you have
really
a schedule.
busy. You're very important,
Exactly. The patient
and
says
like,
all of that. And I might say, but the but in that set, everything you said is true. It's not
mhm.
right or wrong. You're entirely correct.
Yeah.
The but in that
Okay.
sentence, yeah, it
Okay.
didn't feel good, but the but shuts the door
Okay. Well,
on.
let's bring this more. Let's bring it more into the here and now of our time together. You were a couple minutes late.
I was.
I don't. I I don't have any conscious representation of frustration towards that. Now there may be some there, but I have no access to that, you know, and I
Well, I
feel
don't know that it's there either. I mean, it was
okay.
a hypothetical, example, and
But you would be,
the
or I guess I'm just curious, like, would you, like, if I were to say to you that, like, well, I don't really know if I felt anything negative about you being late. I have no access to it. Would you wait for it to slip out like a slip, like a butt, or would
well, the
you?
but is already. I mean, the but is already information.
Right.
Yeah, I had other thoughts, but and I would make that transparent. I would just, I would say pretty explicitly, when you say the but, we get to hear the other thoughts. But the but is the but in that sentence is, shutting the door on hearing
Hmm.
about, you know, hearing about the the thoughts, right? The sentence was going somewhere, yeah, I had other thoughts about it, but, and the but is a change of topic. We don't
Okay.
get to hear
So,
the original thoughts. And then the person might want to tell you the original thoughts, and I don't want to go there just yet. I want to say,
well,
no, there
what
must be a reason.
what if they felt shame in sharing those other thoughts with you, the other
Well, and
emotions they may
and
feel?
yeah, and that's what we'd like to be. That's what we'd like to come out and be able to explore and talk about in words. Because if the person can say, I was angry, or I was resentful, or I was planning a revenge fantasy, which
Mm.
actually wouldn't be uncommon for someone with an obsessive compulsive personality, right? They
Oh.
live in this world of, of being, perpetually between a rock and a hard place, of being controlled by somebody else in a shameful way, or, you know, wanting to be angry and controlling of the other person, in a way that has its own problems. So, the person might have a little fleeting, passing fantasy of
Yeah.
turning the tables or,
And
settling the score. Right? There's a world of difference between saying, well, I was pissed off and I imagined blah, 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 but it's really uncomfortable to talk about. It's really shameful to talk about. There's a difference between saying that something is shameful versus not having it in words, not having it in thoughts, and being controlled by that.
okay. Okay. So I think this kind of is a nice bridge into one thing that I've noticed with a lot of local therapists is when I talk about things like transference, it's like they don't even have a vocabulary for it, or they've heard about it like in some class, but they don't ever work in the transference.
That's for sure.
And or the interpersonal, like the interpersonal maybe a little bit, but like the work that I have been enjoying works a lot in the interpersonal. It's like maybe it's half of the session or more. It's like that, what is going on between us, like that, what you're talking about right now, of like little things, like the little fantasies that come up, or the moments of shame that may come up. It's like, why do you think that working in the interpersonal is so helpful for personality stuff?
Yeah. Well, I would say it's so helpful for psychological difficulties in general, not just for everything. This is when I was talking before about, how DSM,
Mm-hmm.
created some real problems and a devolution in understanding. Everything that we're dealing with in psychotherapy is in the context of the person's personality. You can't separate out, their obsessive compulsive symptoms or their depression or their anxiety or their
Mm-hmm.
avoidance
Yeah.
from their personality. It's all, I mean, our symptoms and our difficulties are woven into the fabric of who we are as people. If we're working effectively, we're always working with personalities. When I say it's woven into the fabric of who someone is as a person and woven into the fabric of their lives, that's another way of saying personality. Okay, so with just
Yeah.
with the clarification that when we're working with something psychological that that's
Okay.
enduring, that's recurring, that's repetitive, that's been enough of an issue that it comes into psychotherapy, we are in the realm of personality, not necessarily personality disorder, but the realm of personality. So, with that said, um, our lives and our minds are organized around certain recurring patterns or themes that we tend to live out over and over again. We form certain relational patterns or templates for what happens in our relationships. We form them through our earliest attachments or attachment relationships, and in one way or another, for better or worse, we relive those patterns further unless something intervenes to change it. We relive
Mm.
those patterns for the rest of our lives. It's not good or bad. It's just the way it is. And if the patterns allow for connection, intimacy, productivity, spontaneity, joy, meaning, well, all is well. If the
Mm-hmm.
patterns get in the way of those things or cause limitations, then all is not well. So the key to understanding transference is, we're forged in the context of our early attachments. We see the world and we see our other relationships with other people through the lenses created by those early attachments. That's
Mm-hmm.
the human condition. Here's where it comes into therapy. I mean, so we replay these relationship patterns. Psychotherapy is also a relationship. There are two human beings in the room. We're having a relationship.
Mm-hmm.
And the patient will bring their lenses or their patterns into the therapy relationship. It's not a matter of choice. It's not you plan to or you intend to or you don't. It just is. You will, in one way or another, start to recreate your relational patterns in the therapy relationship because there's really no choice to do anything other than that.
Right. Yeah.
And that's what we call transference, right? The therapist is a new person, right? They're not, they're not a continuation of the past, of some past relationship. They're a new person that the patient doesn't necessarily know a lot about, and yet the patient attributes all kinds of motives, intentions, thoughts, feelings to the person, right? Which reflect the lenses that they bring with them, certainly as much as the reality of who the therapist is. I mean, so we count on the patient to bring these patterns into the therapy relationship. That's what we call transference. We want them in the therapy relationship because that's where it becomes possible to first to recognize them, not in a intellectualized kind of way. I mean, in a lived way, to recognize them by living them with the patient. That's where it becomes possible to recognize them, understand them, right? And if the work of the therapy is going well, to hopefully find ways to be able to rework them so the patient isn't sort of trapped, isn't doomed to keep repeating the same self-limiting or painful patterns for the rest of their lives. It's in therapy where this can change, and it's infinitely more powerful than somebody telling you about things that are going wrong elsewhere in their lives, something talking about
Right.
there and then. Now we're talking about here and now.
Yeah. What's going on between us.
Yeah.
Yeah. I think part of why I want to bring you on is to hopefully convert some therapists or psychiatrists who are on the cusps or kind of thinking like, how do I want to practice psychotherapy, to kind of think, hopefully not just think, right? Hopefully like feel and participate, and your co-participate with the person that you're with.
Let me broaden that.
Okay.
Even if it's right, because a lot of psychiatrists now don't practice psychotherapy at all. They do medication management practices.
Yeah.
You think transference and countertransference aren't in the room with them at every moment if you're practicing psychopharmacology? Do you think the meaning of a pill to a patient is just a pill?
It's not.
It's not, right? The pill becomes, the pill takes on the meanings that the patient is experiencing in the relationship, so that a doctor prescribes the very same pill to two different patients. For one patient, the pill is like represents the doctor's care, concern, goodness. It's like a piece of the doctor's caring and goodness to take in and make part of oneself. Another patient, maybe someone with a more hostile or paranoid orientation, suspicious orientation, sees it as an effort by a persecutory or malevolent doctor to control them from the inside. Right. So for one patient it's help, for another patient it's a means of coercive control, but it's exactly the same medication in both cases. Right. And I would say that somebody who's just with a purely psychopharm practice, somebody who doesn't recognize this is going to be a lot less effective, even as a psychopharmacologist, than somebody who does understand it.
I still teach the residents at Loma Linda University like 2 to 3 hours a week, and I teach mostly psychotherapy. And one of the things I tell them is that you are practicing psychotherapy if you like it or not. It's either good psychotherapy or it's not so good. And there's this one study, I don't know if you've seen this, but it's like the best study to look at psychiatrist effect. So looking at the effectiveness of imipramine versus placebo. And for those of you who are on YouTube, you can see this little graph here. But psychiatrist one here, his placebo is better than psychiatrist 8 and 9's imipramine. And so, what they found was that there was a huge variability within the psychiatrists. So there's actually something called a psychiatrist effect. And the psychiatrist effect was actually stronger than the
Yes.
difference between the placebo and imipramine. Now,
And,
you
and
could,
and this is an old find. Or this is a newer paper. I'm actually not familiar with this particular paper, but I know of two other papers that basically report the same finding, and that the most effective psychiatrists are more effective with the placebo than the least effective psychiatrists are
right.
with the active medication.
And I mean, you could argue like, and I would believe like it would be different for schizophrenia and bipolar. Like I really do. Or maybe ADHD or OCD. This is depression. So I think there could be a little bit of a difference, and they could argue that. Or like other people will say like, well, imipramine's an old med. But I think the big takeaway is that psychotherapy is happening, and some of these therapists, psychiatrists, were more effective with their placebo than other ones active medication. So irrespective like how the patient feels about you gets internalized into how they take that pill. They're
Of
taking
course it does. And how the patient feels about you gets packaged and internalized with absolutely any quote unquote intervention that you make, right? Which is the fallacy at the heart of manualized therapies, so-called evidence-based therapies. But the defining characteristic of evidence-based therapies is, they're manualized. They're conducted according to an instruction manual which lists specific techniques, specific interventions that the therapist is going to use. And the fallacy at the heart of all of this is there is no such thing as a therapy intervention or a pharmacological intervention in psychiatry, where the meaning of the intervention from the patient to the patient can somehow be separated from their feelings about the
right,
therapist or the doctor
right.
and about the relationship. Right?
Yeah.
It's always right. So the
Yeah.
same intervention for two different patients or delivered by two different therapists to the same patient, it's not the same intervention. And
Mm-hmm.
that's the fallacy at the core of so-called evidence-based therapy. You cannot isolate the
Mm.
effects of interventions from the relational context in which they're offered.
Right. Right. Which is why, you could have better outcomes with one therapist compared to another therapist that are practicing the same modality. And that's why I think the
It's never
interpersonal.
this idea. It's never the same modality. This idea that there's such a
Oh,
thing
okay.
as CBT or psychodynamic therapy or IPT, interpersonal therapy. The
Okay.
idea that there's such a thing as a therapy model that you can isolate from who the patient is, who the therapist is,
Mm.
and the relational, context, the rhythms and patterns and meanings of, of their interactions. The idea that you can do that just doesn't fit.
Okay. I want to jump back to transference and countertransference, specifically for like someone with more of the OCP. I'm leaving out the D.
Obsessive
Um,
compulsive personality, right?
More of the obsessive compulsive personality. Like, what are the common transferences that a therapist will have? Let's start there.
It depends, because the core conflict underlying the personality style is what it is, but the way it manifests in the treatment can be quite different, right? That there's this kind of naive idea that there's somehow a simple one-to-one correspondence. This underlying conflict leads to this, specific pattern of behavior. Well, not so. So somebody with an underlying conflict around, control versus being controlled might be very submissive in the therapy.
Mm.
Very cooperative, a very quote unquote good patient, very deferential to the therapist authority, although their anger and aggression and resentment about it will leak out indirectly. Or
Mm-hmm.
they might be quite openly, oppositional, and argue with the therapist and debate the therapist. The therapist says, could it be that so and so is so? And the patient treats it as a kind of academic argument to to dissect and counter, point by point,
Mm.
but, generally missing the entire point of what the therapist is saying. So.
Mm.
one, one countertransference is if the patient is overtly, controlling and oppositional and kind of one-upping the therapist, one countertransference is the therapist gets very, frustrated and irritated. I mean, they feel like they're trying to connect with this person, and they, they keep walking into a stone wall, and there's a kind of a, subtle coercive put down around it, right? And they start feeling pretty retaliatory, whether they acted on it or not. Which interestingly is exactly the patient's fear, right? If they're defiant, they'll be, they'll be punished and there'll be retaliation. Um, if the patient is, particularly submissive and deferential, um, the therapist might initially feel good about it. They might end up feeling that they might start second guessing themselves. Or are they being controlling and sadistic? Why is the patient, not here as a full person? Why are they just sort of deferentially going along with anything I say versus bringing in their own will and their own wants? And then maybe as time goes on, the therapist starts to realize, we're having all these discussions and the patient is, accepting of everything I say and takes it in and agrees and says all the right things, and nothing ever changes. The therapist starts to feel frustrated. In one way or another, the therapist is going to be a participant in a conflict around control or being controlled.
How does having that knowledge as the therapist help you?
Well, if you try to set aside your countertransference, you're depriving yourself of what is probably the most important channel of communication happening in the therapy. There's three channels of communication in therapy through as the patient communicates. There's the content of what they say, their actual words. There's their nonverbal, nonverbal communication, body language, facial expression, tone, and so on. And there's the countertransference. What do they elicit in you? And we ignore that last that's the one that people are least often trained to pay attention to. It's probably the most important one. It's the one we ignore at our peril. So I would say the most common reaction of therapists is with an obsessive compulsive personality style is you feel like you're sort of involved in some kind of chess match. Every move gets, there's like a counter move, and you're not going anywhere, and you start feeling irritated about it. And somebody who's not trained to think in terms of countertransference has to set that aside and be a good doctor or a good therapist and offer their interventions. But the most important thing that's going on is that there's a quality of a contest or a power struggle in the room. And instead of trying to offer more or different or better interventions or more of the same, right, the value is actually in making explicit that there's a power struggle. You might say to the patient, I'm noticing something, right? Because you're not going to notice this the first time. It's going to happen 10 times over or more before it sort of registers. What the therapist, what's helpful for the therapist to do, they're feeling a certain way, irritated, like they're caught in a power struggle of some kind, but it's very it's very subtle. It's not explicit. I mean, it's not like the patient is saying, screw you don't know what you're talking about. That's a different personality style. Someone with an obsessive compulsive style wouldn't say that. They would fend you off in a more logical, intellectualized kind of way. Well, yes, I could see that. That might be so, but there's always the but. But here's another explanation also, and it could be this also. Well, yeah, it could be this, it could be that, it could be a lot of things. But what's left out of the discourse is, what connects to what the patient is experiencing inside in their emotional life and in their body. So the therapist is becoming increasingly irritated by this, this chess match or this power struggle. We don't want to set that aside. We want to bring that front and center. We want the therapist to pay attention to it. And then what we want the therapist to do after noticing that they're feeling a certain way is, why am I feeling this way with this particular patient? What's going on here between us? What's happening in our relationship? I'm not feeling this way by accident. I'm
Mm-hmm.
feeling this way because I'm, sort of, in the gravitational pull of this particular
Mm.
relationship. And
Yeah.
what's more, whatever is going on in this relationship with me is a window into what's going on and what's going wrong in their other relationships with other people. So I mean, I don't want to, I don't want to close the window or, cover over the window and not see what's
Mm.
in there. It's like, this is a window into the person's day-to-day life.
Mm.
So we're going to say in the therapy, when the therapist starts thinking along these lines and has thought at length, we don't want to just blurt out, we don't want to just register the countertransference and blurt something out. We really want to understand where it's coming from.
Mm.
So the therapist says, I'm feeling irritated. I didn't know why at first, but now I see that basically everything that I say gets, evaded or countered, or deflected in some way.
Mm-hmm.
And it's pissing me off. Now we're starting to get some more information. What is the patient specifically doing that's countering or deflecting? And then at that point, you're in a position to say to the patient, I'm noticing something. I've felt this before, but I haven't really been able to, quite bring it into focus or putting it into words. But I'm noticing that, there's a way that you fend off what I say so that it doesn't really touch you. And then you would name what's going on right here and now. For example, I just said whatever, and you said, well, I could see that. That could be so, but this could be so also. You
Mm-hmm.
see, do you see how when you respond that way, it leaves us both in the dark about whether what I said is something that you recognize, that you feel it, that it
Mm.
applies to you. When I
Okay.
say something and you say, it could be that, but it could be this. Right? Do you see how that leaves both of us in doubt about what your experience is? And, I'm saying this as a monologue. With a real
I
patient, it
like
would be
that.
a dialogue, but,
I like the
a
monologue.
two,
It's good. It's
a,
helpful.
two, a two-way dial. They should say, there's something about that way of responding, I think, keeps me off balance. Never really knowing if I'm offering something helpful or unhelpful. I think there's also a way it keeps you not knowing.
Mm.
As if it's more important to, sort of fend off my idea than it is whether it's right or wrong, to, sort of take it on and chew on it and try it on for size and, and see if it feels like it fits or not.
Yeah. So you're kind of like inviting them into a dialogue of what might be going on between you guys. And then,
Yeah.
of
I mean,
course, a lot
yeah.
could go on after
And if the
you invite
patient
that
is being
dialogue.
really difficult, most patients aren't this difficult, fortunately. Then the patient might then want to argue the point about that. It's like, well, no, I'm not really fending you
Yeah.
off. I
Yeah.
mean,
Yeah.
you're interpreting it that way, but you could interpret it this way and this way and this way, and give you a whole
Yeah. I was
menu of
thinking about
things that
that.
could
Yeah.
be right. And then
Yeah.
the therapist would say, but they really need to stay there at that point. A lot of therapists, when the patient responds that way, they kind of get cowed and they leave the topic behind, and we don't want to leave the topic
Right.
behind. We want to
Yeah.
stay
Yeah.
right there
Yeah.
and say, well, this, the way you've responded to what I said is an example of what
Yeah.
I was describing. I described, I commented that you respond in a way that fends off what I say, that doesn't really take it in for consideration, that leaves both of us in the dark about whether it applies to you or not. And your response to my saying that was, to say something that leaves us both in the dark about whether that's so. I mean, it's happening just here and now. And he says, well, maybe it is, or maybe it's not. Well, what difference does it make? Now, here's where all the knowledge that I have from getting to know the patient in depth over time comes in. It says, well, it occurs to me that there's something about this that's quite similar to, this interaction and that interaction and that interaction that you described with your wife that leaves you feeling, distant and alienated from one another and feels crappy. Well, like, if what's going on here is similar to what's going on there, there might be some real value to you in thinking about it, taking a look at it.
Yeah, that's good. So you're kind of from there bringing it into their more conscious awareness that it goes on. So maybe they
Yeah.
catch themselves when it does happen. And if it doesn't stir up too much sort of defenses against the idea of it, it might actually get somewhere. If it doesn't stir up shame, I think that's where I would say something like, I think that your ability to take this and to intellectually take ideas that are maybe thrown at you and come up with counter ideas is actually really been advantageous to you in your past. But maybe in your interpersonal life, like with your wife, for example, maybe it creates some disconnection. And if it happens here, maybe we could look at what happens between us.
I would want to go. Yeah, I agree. And I would want to go there and bring that into the discussion. But I, I want to keep it in the here and now as much as possible.
Yeah.
Right. I don't want to get into the realm of abstraction yet.
No.
I want to say, do you notice there is something about what we do that keeps me off balance? So I'm never really quite sure how to deal with you. It's really very similar to how you described, and I'd be very specific, what happens with this person in your life, your wife, your son, your friend, your coworkers. Well, I mean, you really want to embed it in specific details about their life. So, it seems like there's something going on between you and me right here, right now, that might shed some light on that.
Yeah. No, but what I'm saying is that I think in the here and now, I'd also try to show them how it's been helpful, maybe to reduce the shame, to get them to be able to grasp it in a way that it's not something that they just push out of their unconscious.
I don't think the patient has access yet in this example to shame. They're not feeling shame.
Okay.
They're just feeling like, well, it could be that, it could be this.
Sure. Okay. Fair enough.
So the next step would be, first of all, do you see how that keeps us both in doubt about what you're actually experiencing? The patient needs to register that. We need to be on the same page. I guess, yeah, I guess I could see how that might leave you in the dark. I still I wouldn't settle for that. You guess casts it in doubt.
Mm-hmm.
You do see how it leaves me feeling like I'm in the dark, or no? Well, no, I do see it. So the missing link in there is perhaps there's a reason for that. It serves a purpose, to keep this in the realm of, kind of academic theories for us to debate about, rather than the realm of, this is about you and your life and it matters. Perhaps there's a reason why you're wanting to keep it at arm's length. The patient says, well, I guess there might be, but, let's find out what comes to mind. And maybe now you get a memory of, something that happened in the past, a time when they felt humiliated or ashamed, right? That they're going to go on a sort of an associative link. They're not going to just come out and say, I feel ashamed. They're going to, if they're talking openly and freely, what we call free association, their thoughts go to another situation. They describe a situation where they came away feeling humiliated or ashamed. Then the therapist can make the connections. Your thoughts went there, right on the heels of, thinking about why you might want to fend this off. It suggests that there's something in this that feels shameful to you. And the patient say, yeah, well, I never thought about it like that. Say, tell me some more about it. Right. So you're sort of opening doors and inviting the patient to come in and explore with you. You're not telling them what their experience is. You're not saying, well, this is because blah, blah, blah. You're not giving them a prepackaged, interpretation of their experience. We don't have access to their experience. What we're doing is, saying, here's a possibility. Let me invite you into thinking about this together. And the patient is the final arbiter. The patient gets to say, yeah, I do feel that.
Yeah.
It was a horrible feeling.
Yeah. Oh yeah, I definitely agree. It's like we don't want to put our experience or put our ideas on them. That would be us intellectualizing on top of them.
Well, that would be like old school, bad psychoanalysis at its worst. That's what everybody is afraid psychoanalysis is about. And of course, that's not at all what psychoanalysis is about, but that's people's stereotype of it.
Yeah. Yep. Well, okay. I know we've gone beyond the time that we were planning. Anything else you want to kind of highlight as we kind of draw this to a close, since we've talked about, obsessive compulsive personality?
We stayed on obsessive compulsive,
Yeah,
but
we didn't get to the other ones.
every personality style, has its preoccupations and will elicit, counter transferences
Right.
in the doctor or the therapist, and the counter transferences are the gateway to understanding what's going on. So I just, just to not leave listeners with, this applies only to obsessive compulsive. I mean, consider narcissistic personality, which is about the patient's internal struggle with feeling, inadequate and unimportant versus feeling, very important and grandiose and quite special. There's this constant interplay between, between these two different ways of experiencing oneself. And, and the patient tries to sort of inflate themselves or puff themselves up and feel important by way of warding off, feelings of emptiness or insignificance or inadequacy. So what does that look like in therapy? One of two things tends to happen. Either the patient idealizes the therapist and sees them as, kind of, larger than life and brilliant and special and important, so they can feel more special by association. But they're turning the therapist into someone other than, a real, whole, three-dimensional human being in the present. Or they subtly or not so subtly devalue the therapist and put the therapist down. So there's two kinds of transferences that we characteristically see. If the patient is being idealized, there's a strong pull from the therapist to kind of join the patient in this mutual admiration society, which is not therapy. Or if the therapist is being devalued, either the therapist, becomes irritated and resentful, or the therapist starts to emotionally withdraw from the relationship, from the patient, right? And that doesn't help either, right? So again, the gateway into how do we work with this in a way that's helpful is to recognize, notice, understand the countertransference, connect it to what's going on in the relationship with the patient that's eliciting these feelings in us, and then bring it into the session for discussion. So I just wanted to put another example on the table.
Yeah. And I think maybe in our time together, we can, I would like to get the full, Shedler breakdown of narcissistic personality. You did a great job in the paper looking at different subtypes and stuff. And I've actually thought a lot about the different subtypes as well. Like there seems to be that psychopathic subtype, which doesn't have maybe some of the same,
yes,
kind of that underbelly devaluing underneath it, like someone with pure psychopathy. It doesn't seem like they have that as much. Whereas, and I think you touched on that a little bit, kind of like that malignant narcissism, psychopathic.
Yeah, well, there's a spectrum, and this is really Otto Kernberg is the theorist who's written the most, and the most, I think the most perceptively about this. But he puts narcissism and malignant narcissism and psychopathy on a spectrum, that they're actually related, related ways of organizing. Where on the spectrum are you?
Hopefully not on the spectrum. I was sorry. I was just bring that to the here and now. No, well, we will leave it there for today. And thank you so much for coming on. I really appreciate it.
Well, it's been a pleasure as always.